My name is Michael Schull. I'm the CEO of the Institute for Clinical Evaluative Sciences, and it's my great pleasure to open the symposium today and welcome you all here. I wanted just to start by saying that while obviously the focus of the symposium today is going to be on the scorecard that's being launched, today is also in many ways a culmination of a whole program of work and research that's taken place at the Institute over the last 5 years. In fact, in 2013, we launched the Mental Health and Addictions Research Program at ICES, and that was the first time that at our Institute there really was a coherent focus and program of research on mental health and addictions. And you could say, how come it took us so long to get there? But nonetheless, since then, there's really been a tremendous amount of work that's been accomplished. And today we'll underscore some of that. I remember the launch. It was at Queen's Park. It was a great event that was held. I actually, as I thought about it this morning, I realized I was wearing the same jacket. And I think I was able to do up the button at that time. I haven't done that today, so we won't talk about that. So today we are launching the first adult scorecard on mental health and addictions. But of course, this is not the first report that we have launched under the banner of this program. There's been the Taking Stock report. There have been 2 children and youth mental health scorecards. All of this, all that done in partnership with Health Quality Ontario, which has been a great partner in this work. There's been a huge progress as well in terms of bringing new data to bear. Clearly, the traditional data and information that we have in our institute that looks at health services is not adequate when you're talking about mental health and addictions care, so much of which happens in the community. And so there's been a tremendous amount of work to bring new data to bear, including the Community Business Intelligence, which links MHA agencies in the Toronto Central LHIN, and which is, as I understand, being rolled out across other LHINs, the Ontario Common Assessment of Need, or OCAN data, and soon we're going to be, as well, working with correctional data to understand mental health and addictions in correctional services, which is really exciting. This is not also just about reports that are being published. This is about how can we make these reports relevant to policy, how we can ensure that policy is being informed by the best evidence and the best local evidence, and ultimately how can that policy result in better services. And so our members of our team have been involved both in the crafting of policy in terms of providing advice, and in how that gets rolled out in terms of services. So I think this is really an exciting moment to kind of look at all of those accomplishments over the last 5 years. Clearly, we've not accomplished this alone. This has been the result of strong partnerships across the environment. I mentioned Health Quality Ontario as an exemplar organization. We have partnerships with a number of organizations that have contributed to this work. The advisory organizations like the CMHA Ontario and the Mental Health and Addictions Leadership Advisory Council, hospital partners, LHIN partners, obviously community partners and agencies, Indigenous partners as well, all of whom have played key roles in getting us to where we are today, and those partnerships will continue to be critical as we move this work forward. So what does the future hold? I think the future is actually really exciting in terms of new opportunities and ways to leverage the success so far to further improve services. This includes more data that's going to be coming online so that we can better understand the delivery of care and services, more finely grained and finely tuned performance measurements so we can better understand how services are being delivered. All of this, I think, is very positive and a testament to the work that's been laid, the groundwork that's been laid over the last 5 years. So today, though, is focused on the first adult mental health and addictions scorecard, and so I'm really excited to see this work presented today. Without further ado, I'm going to introduce. Oh, actually, sorry, I have some people to thank. I realize. That I should make sure I do that. I want to first of all thank the Data and Performance Measurement Task Group, co-chaired by Paul Kurdyak and Upala Chandrasekhara from CMHA Ontario. I want to also thank Susan Piggott from Mental Health and Addictions Leadership Advisory Council, who's a great advocate. Susan, are you here? Not here? Well, thank you anyway. Thank you, Susan. And from the Ministry of Health and Long-Term Care, Patrick Lacerni, the Assistant Deputy Minister for Strategic Policy and Planning, Patrick Mitchell, the Director of Mental Health and Addictions Branch, and Fides Coloma, the manager of the program management unit. So, without further ado, I'm going to introduce Paul, who's going to be your MC for the rest of the day. Paul is the Medical Director of Performance Improvement at CAMH. He's a Senior Scientist and the Program Lead for the Mental Health and Addictions Research Program at the Institute for Clinical Evaluative Sciences and an Associate Professor in the Department of Psychiatry. He's also a very funny guy, so I think he's going to be a much better MC than I would be for the rest of the day. So, Paul, take it away.
Whenever somebody introduces you that funny, that kills. Thank you, Michael. And apologies, I need to stand up here because I need to see the slides, so I don't, because I can't see the screens. Well, to start with, I was thinking as I took this up here, I'm thinking about how I was feeling before today, and it was mostly a feeling of gratitude. First of all, I don't know if you can call something that's free sold out, but this is a free event, but we are sold out, and we have 100 plus participants by webinar who have registered. So to me, that reflects something that I feel is very important as it relates to the work that we do, and that is that while we as a team work very closely, and I'll thank my team at the end, we really, I think, all believe that this is a public good. That what we're doing is important for the entire sector, is meant to be used by the entire sector, policymakers, providers, and people with lived experience. So I think that the fact that you're here and want to participate in the work that we've done is a sign of that sort of sentiment. I'll pull out the clicker. So thank you very, very much for being here. So just some context, this work doesn't exist in isolation. It's an actual part of the 10-year mental health strategy, a mental health and addiction strategy in Ontario. It's a specific, we are part of the budget for the strategy, so that the work that we do is very much supported by and in partnership with the Ministry of Health. And I should mention that it's a 10-year strategy for both the child and youth and the adult sector, and it's also had its beginnings with a really innovative inter-ministerial partnership of Ministry of Child and Youth Services, Education, and Health. A lot of you will have seen this, but I think it's important to reflect on the process by which the work came about, and that is that we at ICES didn't simply make up the things that we're going to report upon. Michael mentioned a data and performance measurement task group, which was a subcommittee of the Ministry of sort of Mental Health and Addictions Leadership Advisory Council. That's all jargon. What it was a bunch of people across the entire sector: community addictions, community mental health, the acute care sector, regional representation, and all measurement experts and advocates who got together to ask the question, what can we measure systematically across the sector? And that was co-led by me and UCLA, but a lot of people who participated and contributed are here in the room. I think as I reflect on the kind of work that we've been doing in the past 5 years in the mental health sector, I think one of the amazing achievements of this task group was the togetherness, was the collaborative nature that crossed the various sectors. Because in my sense, that happens too infrequently. And I think the resonance of the scorecard across the sector reflects the process. And I think that process of trans-sector collaboration needs to be fostered and supported going forth. So very quickly, there are the HQO quality domains: equity, client-centered, safe, effective, timely, and efficient. I'm going to report on the indicators. There are dotted line indicators that the task group felt were not measurable currently, but were very important to be highlighted publicly facing indicators that we can't currently do. And as a sort of a caveat for everything that we're reporting, there are two ways you can go about developing performance indicator scorecards. You can go very conceptual and do this sort of process that solicits feedback on what should be measured, or you can go practical. and look at what you can measure and go from there. We were adamant that we would do the latter because we've had experience in the sector of going conceptual and ending up with really well-developed indicators that are unmeasurable. And we needed to draw a line in the sand around performance and not proceed with the abstract as it relates to measurement in our sector. These are the performance indicators. I'm not going to belabor them because I'm going to go over them in detail, but those are the ones that map across the quality domains. And we also do quite a bit of what we call contextual work. So it's one thing to have a performance indicator. It's quite another to have a broader sense of what's going on in the system. So, how many primary care physicians are there in the system who are working, whose work is devoted to mental health and addictions care? How many patients are seen by psychiatrists and primary care physicians? And as it relates to the feasibility piece, there is a bias towards the acute care sector, and that is purely related to measurability. We feel very strongly, and I'll talk about what we have done and to make strides towards that. We've tried, we understand that we're not capturing very well or at all the community mental health and addiction sector, and that is not an oversight. It reflects the state of measurability that has to be rectified very quickly. Just to start with, some very high-level themes that came out to us as a team when we went over the scorecard. One is that we observe a high mortality rate among individuals with schizophrenia, and it probably generalizes to anybody with a severe mental illness, and I'll show you information on that. Broadly speaking, and across a bunch of the indicators, we're noting that access to care, it remains a challenge and is not keeping up with demand. And there are gaps and transitions in care. And we will have a panel discussion later where experts in the field will be talking about a lot of these issues. But at a higher level, we talk about a mental health system, but what does it mean to be a system? And I don't think this encapsulates everything that a system would entail, but a system necessarily involves a finite amount of resources to provide services and a certain amount of demand, and you'd like there to be some systematic way to align the finite resources to existing demand. And you'd like that the various resources that span across the sector to collaborate and be coordinated in their level of care. And I think it's safe to say that we have not approached that ideal, and that has to be our goal. If we're going to call ourselves a system, we need to be striving towards being systematic in the way we deliver care to people who need our services. So let's start with safety as it's the good news story. I do my work in an emergency department, the CAMH Emergency Department downtown Toronto, where unfortunately there are not an infrequent number of individuals who come seeking our care who are in such a state that we need to put them in mechanical restraints. This is something that we hate doing. This is something that's experienced by that anybody would experience as traumatic, but particularly individuals who have mental illness and addictions issues, and the expected histories that these individuals have. It's a very traumatic experience. So I view this as an unbelievable amount of progress across the system, that there's something happening as it relates to the way that we are engaging with individuals in our hospital setting, that the use of restraints has gone down by a third between 2006 and 2014. The target is 0. I'm not sure that we will ever get there, but we are achieving progress. And I think that reflects a lot of things, but I think it hopefully reflects the patient-centeredness of the way we deliver our care that translates into reductions in restraints. Restraint use is, interestingly, an equal opportunity event. In every other aspect of when we look at mental health outcomes across income quintiles or income as a determinant of our restraints is not one that plays out by income. It does, however, play out by immigration status. And this is supported by work led by Maria Chu, one of our project scientists, who published a paper showing that individuals of South Asian and Chinese ethnicity show up to hospitals with a more severe form of illness. So that's one possible, as we triangulate our work and try to look for explanations. It may be that individuals of certain ethnicities are seeking care late and in a more severe state. So there's probably some engagement work that needs to be done to reflect the inequity that we're observing in restraint use. Effective is the mortality work, and this is work led by Jenny Gatoff, who was a student and then is now one of our epidemiologists. And it was also a collaboration with Laura Rosella, an ICES scientist at the Atlanta School of Public Health. And this just shows over time this. So what we're showing here is the years of potential life loss, and essentially the way this works is it's the number of individuals, it's the number of years below 75 that you die. So if somebody with schizophrenia dies at 50, that individual contributes 25 years to the years of potential life lost. It's that simple. And what we're seeing is that there's just an overwhelming mortality gap that we observe amongst people with schizophrenia, and it is not changing. It's hard to see because the schizophrenia rate of mortality is so high, but the mortality in the general population is going down. So this, on your left, you'll see that this is the same thing, the five-fold, but I think there's some interesting stories that unfold within the specific causes of death. So suicide is not surprisingly a huge determinant of these years of potential life loss amongst individuals with schizophrenia. But the other piece that's equally interesting to me is if we look at, and I'm going to wander and use my clicker here. So I want you to focus on, this is cardiovascular deaths and this is cancer deaths. I'll do it over here. This is cardiovascular and this is cancer. The orange is schizophrenia and the blue is the general population. So in the blue, you'll see that the cardiovascular death is quite low and the cancer death is actually high, relatively speaking. And that's what Laura and her team have shown, is that over time, a death by cancer is a luxury as a result of a reduction of cardiovascular deaths over the past 20 years. And what you see in the people with schizophrenia is that they are still more likely to die by cardiovascular reasons. So they have missed out on, individuals with severe mental illnesses like schizophrenia have missed out on the public health benefits that have resulted in a reduction in cardiovascular deaths. And how you address that is remarkably complex, but if you don't address it, you end up with a substantial contribution to this mortality gap that's been so persistent. And this is another troubling finding, that there has been absolutely no change in our suicide rate over the years that we have studied it. It's been actually, we go back further than 2006, and it's been a flat line. The geographic distribution, the darker areas are areas with higher rates of suicide, and the real issue is that the suicide is not a geographically equal phenomenon, that there are areas in the north where suicide rates are substantially higher. Interestingly, not as high as the disparities we observe regionally in the child and youth sector, but still the disparities remain. Timely is a difficult one. Obviously, we would love to have wait times in our sector, and there's an initiative going on with the collaboration with CCO and some of the hospital partners on developing wait times. But in the absence of wait times, we do have one measure. We are really thrilled with it. This is a new indicator. We reported on this in the child sector. And here's how this works. We take everybody who shows up to an emergency department in Ontario for a mental health and addiction reason. That's the denominator. That's the pool of individuals. And then we look back 2 years within the physician visit data to see whether they've had any contact with a psychiatrist or a primary care physician for a mental health reason. And what happens with those individuals, it means that they are showing up to an emergency department having seen no one for a mental health or addiction reason in the previous 2 years. They just show up. And what really bothers me about this finding is, and again I'm going to have to wander, this light blue line that's the 16 to 24-year-old age group. That's the transitional age youth group that we so often focus on. And if you think about what happens between 16 and 24, is that's the age of first onset of adult mental illnesses. So this is a really striking finding that 45% of transitional age youth are showing up to the emergency department having had no prior contact with the system for mental health and addiction reasons. We need to be, if we're serious about early intervention, we need to do a much better job at configuring our services to meet the needs of these transitional age youth. Contextual findings on your left are the rates per population of primary care physician-related mental health and addiction visits, and on your right are the psychiatrists. So there are two things that you take away from this. One is primary care physicians provide, as it relates to physician-based care in the mental health and addiction system, they provide the majority of the physician-based care. They're doing the lion's share of the work in the community. And if that's the case, the other concerning piece is there's a really marked decline in primary care physician engagement in mental health and addictions care. And we don't really know why this is happening, but this is a concern because I'll go on to show you what's happening in the acute care side of things. So this is our unscheduled ED revisits within 30 days. You have an emergency department visit, and we look at the rate at which you have a subsequent ED visit within 30 days. And you can see things that aren't terribly surprising. The men have higher rates of unscheduled ED revisits, and here you have this sort of 25 to 64-year age group that is at highest risk. And here you can see that very typical income gradient, where if you live in a lower income neighborhood, you are probably having access issues as a result of your socioeconomic status, and you're more likely to bounce back. This is a complicated slide. So this is the rate at which you are seeing a physician within 7 days of psychiatric hospitalization discharge. The blue line is any physician visit, which is a psychiatrist or a primary care physician. The yellow line, the yellow line is primary care. The reddish orange line is the psychiatrist, and the little green line is seeing both a primary care physician and a psychiatrist. And the lowest rate of post-discharge follow-up is among individuals who are discharged with a diagnosis of schizophrenia. The other troubling issue relates to the first diagnostically specific category, which is substance use, and I'll point to that in case you. So this is schizophrenia. This first one is substance use disorders. Over here, this is substance use, and that's schizophrenia. We keep seeing this in our data through studies, that if you focus on the orange line, you can see that if you're diagnosed with a substance use disorder, you're half as likely to see a psychiatrist after your hospitalization than if you have any other disorder. And we see this over and over and over again, that the psychiatrists in Ontario, we don't know why, but they are far less likely to provide access to individuals with addiction issues following emerge visits, following hospitalizations. And you know, for me, again, reflecting back on my clinical work, the notion that individuals with substance use disorders only have substance use disorders is quite ridiculous. I can't remember the last time I saw somebody who was suffering from substance use disorder issues who didn't also have some mental illness issues as well. Comorbidity is the norm. So this necessarily means that they are a complex population and probably need more care rather than less. When we look at 30-day readmission rate, here what really jumps out is that individuals with schizophrenia are much more likely to be readmitted within 30 days of discharge. So let's go back one. People with schizophrenia are least likely to get follow-up after hospitalization, most likely to bounce back within 30 days. And obviously the reasons for that are complicated, but from a system perspective, you can't call that efficient use of resources. This is one of our contextual indicators, and it just looks at the rates of mental health and addiction-related hospitalizations over time between 2006 and 2014. And again, I draw your attention to the light blue line. Those, again, are the transitional age youth. And there's something going on in this age population where they are coming, and we've seen that at CANH, the proportion of our patients who are transitional age youth is going up. And if we look at non-administrative data, it actually looks like the prevalence of depression and anxiety is also going up in this age group, and there's all sorts of theories about why that is. Sociologists are trying to unearth the role of the iPhone. No matter what it is, what we're seeing is overall is this decline in primary care doing mental health services, a relatively low rate of psychiatric availability in the community, and a real steady rise in this transitional age youth using acute care services. And we also see in our child and youth scorecard, and we report in the chart pack. Feel free to look at the large chart pack in your spare time. But we also see that this transitional age youth group is one of the fastest rising groups using mental health and addiction as emerge visits. So the acute care sector really is this sort of canary in the coal mine, looking at the efficiency of the broader sector as a whole. This is the last performance indicator slide, and here we are grateful for access to care from CCO for providing us. What is ALC? ALC stands for Alternate Level of Care, and that occurs when somebody is in a psychiatric hospital bed and no longer requires the intensity of services that are delivered in a psychiatric hospital, but are not able to be discharged because there's no available adequate supportive resources in the community. So they don't need the hospital, but there's not anything in the community, so they end up staying in the hospital and using the resources of the hospital for lack of resources outside. And it's a little bit confusing. On your left, to see the wait times for supportive housing amongst those who are discharged. So if in those given years from 2012 to 2015 an individual was discharged, their wait time was about 50 days. But that's less impressive than if people were not discharged, which means the ALC, at the end of the year, the ALC application remained open. In other words, people are still in the hospital. And here, I think what we're seeing, like the average goes from 250 to 300, and I think it's pulled down below a year just because people are admitted into the hospital in between years. But essentially what you're seeing is people who are having to remain in hospital for a year or longer as a result of the inadequacy of resources in the community to provide support. So this is another sort of huge transitional issue, and I don't know, I have colleagues in the room who can speak more eloquently to this, but this is a big transition issue where there's this sort of gap between what we do in the hospital and what we do in the community as it relates to the more complex clients that we serve. So I certainly don't, I can tell you what the future directions are for our group. The future directions more broadly is really up to all of us and beyond us, but so the first important thing is that the work that we do, Michael in his introduction said that we were launched as a program in 2013, and that's, if I think, part of these days for me is an opportunity to reflect. So in 5 years' time, we have systematically and routinely and put a lot of effort into working with our data that we have at ICES. And in so doing, we've uncovered a lot of quirks and bugs. So there's a continuous quality improvement process. Whenever we work with our data, with every report we uncover weirdness and we have to address it. And we also have opportunities to think conceptually. So for example, that first ED contact, looking at the proportion of individuals who are invisible to the system show up to the emerge. That has never researched. No other jurisdiction reports on that. I think we've developed the first indicator for access in the system in the world, which is a really amazing thing. It tells us something. So there's a lot of work that we continue to do internally. We need to start addressing more new indicators, because I think that it's safe to say that while these indicators are telling a story, they are far from telling the whole story. That when I listen to my work, the stories of individuals who come to seek care at our emergency department, if you think about the people you come across, what we can report on doesn't tell the totality of their experience of their illness, and certainly it doesn't tell the totality of the experience of our system in trying to seek help for their issues. Michael also touched upon this, the new data sources. So we have a working group working with community business intelligence from Reconnect, and this looks at all the community mental health and addictions plus some community care resourcing data from the TC-LIN, and we're just getting started to do some really innovative work. So now we know, for example, when somebody is discharged from an emergency department through the linkage for a mental health and addiction reason, what proportion of them could show up for community addictions in the TC-LIN. We can start looking at that system-wide transition piece. We also have an OCAN working group, and we've set up a committee to try to understand the nature of OCAN, the breadth of OCAN, the structure of OCAN, and how we can use that. Across ICES, we have the Ministry of Community and Social Services data linked, and that's my colleague Astrid Gutman is leading that process with the team, and that's going to be very, very important. I think, I can't remember, Astrid's just stepped out, but I think 40 to 45% of Ontario disability support applications are mental health and addictions related. So this is going to be a very important story to tell. And we're also hopeful in linking the DATAS, which is housed at CAMH and 180 plus community-based addictions treatment agencies in Ontario. Their information all flows into DATAS, so we'll be able to tell province-wide how we're doing from the totality of the care that we provide to people with addictions. That's just the measurement agenda. I, for one, don't want to spend the rest of my life measuring stuff. It gets to, why do we do this? We do this because this data represents the status quo, but it also represents a benchmark, it represents a baseline. But it is only a baseline if we respond to it. If we don't respond to it, it represents measurement over time, and we can't expect anything to change if we don't do things systematically. So I think it's huge progress that we're able to measure the way we can after 5 years of existence. But I would like us to see as a sector to start systematically targeting some of the issues, the transition issues, the access issues. Because now that we can measure them, the question is, what are we going to do about them? And there are things that are happening, and the purpose of the panel is to invite some really exceptional individuals who are working within the sector on addressing some of these issues that have been highlighted, because I think we as a sector need to start wrapping our heads around implementation, intervention, evaluation. We need to start doing the sort of quality improvement kind of work that starts going after the kind of things that we can measure, so that we're not just measuring. And with that, I did say I thank my team. So this comes back to the gratitude piece. We are so grateful to be supported, to have developed the team that we have. This is in alphabetical order because that's how we do. We're very egalitarian. Astrid Gutman and I have been working together on this massive team on the child and adult front from the beginning. We have amazing scientists involved: Simone Vigod, Natasha Saunders, Maria Chu, our project scientist who's off on maternity leave. We now have our own analyst, Simon Chen, and we have the epidemiologist, Abby Amarty and Jenny Gatoff, and Michael Liebenbaum, who's left us to go do a PhD and works with us part-time. And last but certainly not least, Julie Yang, who runs the show. And just wanted to announce, where is Julie? Here she is. This is her last day. She's accepted a job with the Ministry of Health, so we're really happy with her, but I just wanted to publicly make a shout out to Julie. It's been a fabulous 6-year run, and we're so grateful for all you've done for our program, and we wish you the best. And she put this together. So if everybody could just, I just want to give Julie So I hesitate to say we can have questions. I won't, I'll do my best to field questions if there are any. Or we can have there are mics, we can start floating mics around. So are there any questions? Sorry, one last thing. That's why so a ton of people also supported. There's lots of ICES resources going towards this. Another shout out to the Data and Performance Measurement Task Group. We had 2 reviewers, Naushka Degani, who was on the Data and Performance Measurement Task Group, as was Rachel Solomon. And we also got data from a bunch of different sources. So thank you very much. This was a very, very large collective effort. Okay, now we can have questions.
So first of all, Paul, thank you for a very comprehensive and informative presentation. The question I had, and I didn't memorize your previous MHASEF reports, but the light blue line that you highlighted in the 16, the transition age youth, how does that dovetail with what you found for the children and mental health report card?
Oh, well, in short, it's identical because, and that's not an accident. It's identical because, when we constructed our approach to the different strategies, we felt that it's artificial to think of these things as separate. Like a transitional age youth does not experience their care within systems, they just want care. So we did 2 things to address that aspect. One is that we harmonized our indicators whenever possible. So we wanted to measure the same thing, even if they played out differently in different systems. And our child and youth scorecard went up to 24, and our adults started at 16, because we wanted to look at the transitional age issue from the bottom and from the top, if you like, from where they start and where they finish their transition. So it's identical. So what we are presenting here as the transitional age youth would be the oldest age category in the child, and we do that very purposefully. Yeah.
Thank you, Paul. I'm just wondering from a sort of general hospital acute care perspective, because I'm not as familiar with how the data becomes the data on the sheet. I was struck as a general hospital psychiatrist around the restraint issue, and also thinking as a geriatric psychiatrist around geriatric issue, and I'll make that more clear in a sec. I guess what I'm wondering is, as you look at the good news story around restraints, does that come explicitly from inpatient psychiatry as opposed to kind of general hospital use of restraints? Because I think many kind of general hospital psychiatrists would observe, as we look at inpatient psychiatry compared to the rest of the building, if you will, that there's in general more restraint use in sort of the rest of the hospital as opposed to the beds, even if you take into account that there are more beds.
Yeah.
So I'm curious.
It's a great question. So the answer to your question is first a data question. We only gather restraint use from the RAI, which populates the Ontario Mental Health Reporting System, which comes from psychiatrically designated beds. So what you're observing in non-psychiatric beds, so for example, if you're going out and providing consultation service or providing input to individuals with psychiatric issues in non-psychiatric beds, that restraint use is not being captured. So your observation might be absolutely accurate. So then the question is, how do we translate? Oh, and the other piece is that because of the way the Ministry of Health conceptualized the mental health strategy, dementia is not part of our codes. So that's another important piece that would be very relevant to your practice. So, then the question is, what has happened in our sector that has translated into this reduction of restraint use? And I don't think we know. I know at CAMH we had a massive organization-wide every leader went out to, spent a 2-day training session from this US team who talked to us about what it would take organizationally to reduce restraints. And it was serious. And then we systematically went after our restraint use. And I was the director of our emergency department at the time. And the emergency department is probably the hardest place to reduce your restraints because of the need. Like we don't know the individuals coming in. We don't know anything about their pre-arrival status. Having said that, I do recall we reduced our restraint use in the emergency department over, I think, a year by 80%. So there's a couple things. So to answer your question, you may very well be observing what is true, which is a rise in restraint use in medical beds for people with psychiatric issues. But then the question is there an opportunity to understand what has occurred in our psychiatric beds and translate those learnings so that people who don't necessarily have our expertise we can translate our successes so that people can avoid these traumatic experiences outside of the psychiatric area. Thanks for the question.
Thanks so much for that. That was an amazing presentation. Anna Greenberg, Health Quality Ontario. I just want to ask two actually fairly minor questions. One is on understanding follow-up for substance use. You talked about dual diagnosis or comorbidity and how we can understand that in the other follow-up, so for schizophrenia and other diagnoses. And the second question is just whether on the ALC we're able to unpack what diagnoses are waiting.
So if I understand the first question is what happens and what should happen for people with substance use disorders, or
whether we're able to understand, because we have your graph shows substance use on its own, but you talked about dual diagnosis or
right.
Yeah,
got it. So what that substance use on its own represents, and that's hospitalization data. So that means that the main diagnosis attributed to that hospitalization was substance use. In the same way that the schizophrenia group is the main diagnosis of schizophrenia, but we know that a lot of individuals with schizophrenia also have issues with substance use. So what this just tells you is that if your main diagnosis is a substance use disorder, what I said is that that doesn't mean that's all they are struggling with, and that's what everybody's experience is clinically. But it does mean that if the system identifies that individual as primarily suffering substance use disorder, something is happening that translates into lower psychiatric care after hospitalization. And to me, that's a problem, knowing what I know about this patient population. And I would think that beyond that, I think if we looked at substance use as a general comorbidity rather than the main diagnosis, we would see the same thing playing out, that there's something happening. And that's kind of what we do see. When we look at emerge visits, we see the same 50% drop when substance use is in the mix. The ALC, I am looking to Julie on her last day, and the answer is no. She's shaking her head. She's working on her last day. Okay, more from the boss. There we go. Oh, okay.
Noshka again from Health Quality Ontario. I want to follow up on Anna's question on the follow-up by physician for different conditions, and I'm wondering. So it's really important that we have a sense of the follow-up, and I know one of the gaps we have in our understanding from our data is other types of service providers. So how critical is it, like from an evidence perspective, that a person see a physician?
Well, so this gets back to feasibility and measurability, and so that's an interesting question. It's actually a testable question. We've looked at this. We've looked at this systematically. It was a study published in Psychiatric Services where we took individuals with a diagnosis of schizophrenia and followed them after discharge. And the story is that seeing any physician across the whole population helps reduce a subsequent readmission a little bit. So it does have an effect, but the more interesting thing is we used a risk prediction for readmission developed by Simone Vigod, one of our colleagues, to then categorize the discharge population as individuals who are low, medium, and high risk. And it turns out that if you're at low risk of readmission, the rate of readmission is so low that it doesn't matter whether you see a physician or not. And in the middle it starts to matter, and then when you're high risk of readmission, the physician has a huge influence and the type of physician starts to matter. So individuals who were followed by psychiatrists had a significantly lower rate of readmission than individuals who weren't, who were only seen by primary care physicians, and the rate of readmission was quite a bit lower than individuals who saw nobody. So we now are generating evidence that it does matter, but beyond that, what is a reasonable system response after discharge? To me, that's a more important question. So what's the number one reason why people get readmitted, and at least in my experience in the emergency department, for people with psychotic illnesses, because they've stopped their medications. If you don't see anybody in a month, you're completely unable to fill your medications, even if you're getting amazing community-based services, right? Because the average discharge prescription is like 2 weeks, a week, 2 weeks. So there are structural issues that are preventing people from maintaining the care that we've invested so much in the hospital to use to stabilize the individual. So I think, but to me, the bigger question is, the system response. And we're starting to get at that with that sort of low, medium, and high, which is, should we be just providing services, or should we be aligning the intensity of services with need? And that involves engagement with the community, that involves rapidity and frequency of physician resources, and it involves those two things to be highly integrated, and so that takes a lot of work, and at least in my experience, and I see the failures obviously in the emergency department, but the failures occur because those things aren't happening. Yeah. Okay. Can we stop now? All right, so we'll take a break. Perfect timing, right? So we scheduled a half-hour sort of networking break. When we come back, I'm going to lead you through a panel of these three amazing researchers who've become. Thank you very much.